Hello friends, welcome to this module on mitral stenosis. So as I've already mentioned in my previous modules that when you are dealing with the cardiovascular system, the diseases are basically divided into the diseases of the endocardium, myocardium, pericardium and diseases of the peripheral blood vessels, right? So when we deal with the diseases of the endocardium, diseases of the endocardium basically means the involvement of the valves. So one of those involvement, which is the mitral valve involvement, and the mitral valve involvement can be in the form of stenosis or regurgitation. So mitral stenosis will be the topic of discussion in this module, right? So before we move into the mitral stenosis proper, let us revise the anatomy of mitral stenosis. How does the mitral valve look like? Okay, so we have posterior leaflet, we have the anterior leaflets. These leaflets are bounded by what is known as the annulus. We have the something known as the annulus. To support the mitral valve, we have two things known as the chordae tendineae. These are the thin cords that support on the papillary muscles, on the papillary muscle. So these entire structures are basically known as the mitral valve apparatus. Now, what important thing you need to remember is what is the normal area of mitral valve. What is the normal area of mitral valve? You have to remember, and answer is 4 to 6 centimeters square. Okay, answer is 4 to 6 centimeters square. This is the normal area of mitral valve. This is important from the exam point of view because when I will teach you what actually is the reduction in the mitral valve orifice in the mitral stenosis, then you will come to understand. Okay. So what are the causes of mitral stenosis? From practical point of view, whenever you start seeing cases in your ward and when you do your clinics and all, you will see that the mitral stenosis, the number one cause is rheumatic heart disease, second is also rheumatic heart disease, third is also rheumatic heart disease. So such is the affliction of mitral valve in cases of rheumatic heart disease, right? But from theoretical point of view, the first and the most important cause is rheumatic heart disease. So this is the most common cause. Second, we can see in SLE and rheumatoid arthritis patient. Third, we have certain congenital MS like parachute valve or cor triatriatum. Now, what actually is basically called triatrium? It is a supravalvular mitral stenosis. Pay attention to this diagram. If this is the left atrium, left ventricle, and this is the mitral valve, what we have in cor triatrium is we have an obstructive membrane here. We have an obstructive membrane here. So above the level of the valve, supravalvular, you have an obstructive membrane that gives rise to mitral stenosis. Okay. Next is myxoma. Cases of myxoma can also have mitral stenosis. Infective endocarditis, an important cause of mitral stenosis. Then when you have severe mitral valve, severe mitral annular calcification that is extending up to the leaflets. Then you can have mitral stenosis. So what is the pathophysiology of mitral stenosis? Let's read that. To understand any valvular pathophysiology, the best thing is to form the box diagram. Right? So this is the left atrium, this is the left ventricle, this is the right, and this is the atrium and ventricle, and these are the mitral valves. So what actually happens is, left atrium pushes blood into the left ventricle. Now what you are having is a stenosed mitral valve. So the blood is getting very small space to go to the left ventricle. So what is happening here is there is increased LA pressure. And this increased LA pressure is transmitted to pulmonary veins, from the pulmonary vein into the pulmonary artery, to the right ventricle, and finally to the right atrium. So this is basically a vicious cycle. So if you are asked which is the chamber of the heart that does not enlarge in mitral stenosis? Answer would be left ventricle. The answer would be left ventricle. Okay, the answer would be left ventricle. So left ventricle is the chamber of the heart that does not enlarge in mitral stenosis, and I have explained you very well the pathophysiology. So what actually determines the severity of MS? The gradient between LA and the left ventricle, which is known as the transvalvular gradient, It basically determines the severity of MS. Okay. So next we shall move into the clinical features. Now mitral stenosis can remain asymptomatic for a long time. It can remain asymptomatic for a long time, but there are conditions when it can produce symptoms. The first and foremost symptom for mitral stenosis would be dyspnea. You can get dyspnea on exertion. These patients cannot tolerate tachycardia at any cost. So, a patient who is compensated mitral stenosis suddenly can get decompensated with the onset of tachycardia. So, what are the conditions that can cause tachycardia? Conditions where there is sympathetic excess will give rise to tachycardia, and tachycardia will not be tolerated by MS patients. Why? Because say the blood is moving from the left atrium to the left ventricle. Because of the stenosis, small amount of blood comes from the left atrium to the left ventricle. So that small amount of blood is being pushed to the aorta, and the aorta is sending it to maintain the cardiac output. Now when there is tachycardia, so you know when there is a tachycardia from the physiology classes, you know that the time for the systole and diastole gets shortened. So if it is shortened, so the less amount of blood will come. If the less amount of blood will come, there will be less cardiac output. So you will start having symptoms, and there will be more accumulation of blood in the left atrium. So from the backward flow, the blood will start producing symptoms. You are accumulating blood in the left atrium, so it is going into the pulmonary veins. Into the pulmonary veins, it will cause dyspnea, it will cause edema, it will go back to the right ventricle. So tachycardia is one such thing which cannot be tolerated by MS patients. It will lead to decompensation. So any causes of sympathetic excess shall give rise to decompensation in mitral stenosis. So fever, stress, anxiety, infection, thyrotoxicosis, AF, pregnancy. So these are the important things that you need to remember. And one thing you need to keep in mind that in pregnancy, the MS gets decompensated. MR may not get decompensated, but MS may get decompensated, right? So this is an important MCQ that you need to keep in your mind. Second, due to the backward pressure from LA to the pulmonary veins, then to the pulmonary vasculature, you can have hemoptysis. Right? Now, hemoptysis can be due to the recurrent pulmonary infections, can also be due to some condition known as pulmonary apoplexy. So, you have to remember what is known as pulmonary apoplexy. Now, what is pulmonary apoplexy? It is basically hemoptysis due to rupture of bronchial veins. So in neurology, you read about something known as the pituitary apoplexy, and in cardiology, you have to read about what is known as the pulmonary apoplexy. So pulmonary apoplexy is basically the hemoptysis due to the rupture of bronchial veins. Okay. And I mentioned that you can have recurrent pulmonary infections. You can have pulmonary infarction. And you can have what is known as the most dreaded part, thromboembolism. Now, why there can be thromboembolism? Why? Because the left atrium is enlarging. There is enlarged left atrium. The enlarged left atrium is forming a nidus. It is forming a nidus for thrombus. It is forming a nidus for thrombus. Now, this nidus for thrombus will get dislodged with atrial fibrillation. Will get dislodged with atrial fibrillation. So, thromboembolism is also one of the symptoms of mitral stenosis, or you can say it is one of the complication. And one more you can get, which is known as the Ortner syndrome. Now, what happens in Ortner syndrome is, due to the enlarged LA, there is hoarseness of voice. Due to enlarged LA, there is hoarseness of voice. This hoarseness of voice is due to the enlarged LA compressing on the left recurrent laryngeal nerve. Okay. So, we have read about the clinical features of mitral stenosis. Now, we shall move into the findings of mitral stenosis. Now, before I move into the findings of mitral stenosis, in my previous modules also, be it JVP or heart sounds, I have described the physiology of cardiac cycle. You have to remember cardiac cycle, otherwise it will be very difficult to understand any sort of mitral valve disorders or the aortic valve disorders, because you are going to need this thing, cardiac physiology, especially the cardiac cycle at any step. Every step you are going to need it actually to explain why the murmur is getting systolic, why the murmur is diastolic, right? Why you get opening snap as a diastolic sound. So you need to know. So let's quickly revise the cardiac cycle. Okay. So cardiac cycle, basically, we talk about the ventricular systole and the ventricular diastole. The systole is 0.3 seconds and the diastole is 0.5 seconds. So first we start with the atrial systole. We start with what is known as the atrial systole. The atrium contracts for the 0.1 seconds, right? And then we get what is known as the S1. Then we get what is known as the S1, which is the closure of the AV valves, right? So closure of the AV valves gives rise to the first heart sound. At that point of time, the ventricles contract as a closed chamber. So you get what is this phenomenon is known as the isovolumetric contraction. And at that point of time, there is opening of semilunar valves. There is opening of semilunar valves. So there is rapid ejection. After that, you have the slow ejection. And then due to the inertia, the blood still flows from the left ventricle to the aorta, which phase is known as the protodiastole. That phase is known as the protodiastole. Now, at this point of time, what you get what is known as the S2. This is the closure of the AV valve. This is the closure of the AV valve at the onset of ventricular diastole. Now, here at this point of time, your valves, AV valves and semilunar valves both are closed. Then comes the opening of AV valves here. At this point of time, your opening of AV valves. Right. So opening valve basically opens after some point of time of S2. Right. So when the opening of AV valves occur, then comes the rapid filling phase and the slow filling phase. So when the opening of AV valves occur, this explains why the murmur of mitral stenosis is a diastolic murmur. And since it is starting after some point of time of S2, because this is the phase, see, this is the time taken by the AV valve to open. This is the time taken by the AV valve to open, the mitral valve to open. So that's why what you get is known as a mid-diastolic murmur, right? That's why you get what is known as a mid-diastolic murmur, right? We will come to the murmur part, but I'm explaining you the physiology. So that's why you get what is known as a mid-diastolic murmur. So the murmur will start from here and it will go up to here. And at the end, the ventricular diastole has not got completed, and at the end when you have the pre-systolic contraction, when you have this atrial contraction, that's why you get what is known as the pre-systolic accentuation. That's why you get what is known as the pre-systolic accentuation. So the cardiac cycle is very important to understand the cardiac physiology to explain the murmurs and the different types of disorders. Okay. So now we'll go to the what findings do we get, right? What findings do we get? We have discussed about the clinical features and now we will get the findings. We'll study about the findings. Okay. So if you inspect the patient, on inspection you get something known as the malar flush. You get something known as the malar flush. Now you remember in your clinics you have been taught that the cardiovascular examination starts with inspection, then palpation, right? You go to the percussion. Percussion is hardly done in the cardiovascular, and then you have the auscultation. So that does not mean that the most fascinating part, which is the auscultation, you jump into that. Okay. So we will start step by step. We will read about the pulse, JVP and all these things. So before inspection, let's say what will be the pulse in mitral stenosis. Usually the pulse in the mitral stenosis is either normal or a hypokinetic pulse because we have a low cardiac output state. Okay. So normal to hypokinetic pulse you can get in mitral stenosis. You can get a irregular pulse if the atrial fibrillation sets in, right? So you can get a irregular pulse if the AF sets in. So if the AF sets in, you're going to get irregular pulse, right? What will you get in JVP? In the JVP, normally you will get A waves, right? Now, as I mentioned, left atrium, the blood increases, goes back to the pulmonary veins. From there, it goes to the artery, from artery to the right ventricle. So this way, what you can get is a tricuspid regurgitation, secondary tricuspid regurgitation. So if you get a secondary TR, what will you get in JVP? You will get CV waves. So if you have TR, you're going to get CV waves, or you can get V waves, right? So this has been taught in your JVP lecture. And if you have AF, you're going to get absent A wave. And if you have AF, you're going to get absent A wave, right? Now, on inspection, you're going to get malar flush. Now, what will you get in palpation? What will you get in palpation? We call this type of apex known as the tapping apex. This is due to the palpable first heart sound. This is due to the palpable first heart sound, right? So what you have to remember is in mitral stenosis, what the apex that we get is tapping apex, right? It is in the same space because the left ventricle is not enlarged. The left ventricle is not enlarged. I have mentioned it. So you're gonna get a tapping apex at the fifth intercostal space, but the apex will be tapping due to the palpable S1. Okay. Now, if simultaneously if you get RV enlargement, then you can get what is known as the parasternal impulse. Now, let's move on to the next part, which is the hot favorite of everyone, which is the auscultation. So, what will you get in auscultation? The S1 in MS is loud. What we get in MS is loud S1. A sharp, loud and accentuated X1. So that is a classical feature of MS, right? That is a classical feature of MS, that the S1 is loud. If valve is calcified, if the valve is calcified, you will get soft S1. If the valve is calcified, you will get soft S1. This you need to remember. The calcification of the valve, when the pliability of the valve is lost, you will get soft S1. Second, you get one of the diastolic sounds known as the opening snap. Right? Now this is the S1, this is the S2, it has the A2, P2, and this is another S1. So this is systole, this is the diastole. So you get here something known as the opening snap. The opening snap is basically due to the opening of the AV valves, right? So you get what is known as the opening snap. So again, opening snap will be absent when the valve gets calcified. This will be absent, and the severity of MS is based on this gap, is based on the A2 P2 OS gap, right? Is based on the gap between the second heart sound and the opening snap. So if I say the gap is small, the severity is more. If the gap is wide, the severity is less. Okay, so this is about the opening snap. Then comes the murmur. Then comes the murmur. What sort of murmur we get in mitral stenosis? I've explained to you in the physiology just before that you are going to get a diastolic murmur in MS. You are going to get a diastolic murmur in MS. So what we get is a low pitched mid diastolic murmur. Just after OS, right? And it has got a pre-systolic accentuation. So what happens? S1, A2, P2, S1, right? So here you get OS, and after this you are going to have the murmur, and just prior to that it has got a accentuation. This is the pre-systolic accentuation. This is what is called as a pre-systolic accentuation. This is due to the atrial contraction. So if you have AF, this pre-systolic accentuation will be lost. This pre-systolic accentuation will be lost. Okay. Now what is basically severity of MS? What do you mean by severity of MS? I have mentioned before that the normal orifice is 4 to 6. The normal orifice is 4 to 6. Okay. Now we call it a severe MS when the orifice area is less than 1.5 centimeter square. This you have to remember. It's an important MCQ that is asked. Okay. It is an important MCQ that is asked, that severe MS is less than 1.5 centimeter square. Okay. Now, how do you clinically judge the severity of MS? I have mentioned that if there is a soft S1, that means the valve has calcified. So soft S1 is basically the marker of severity of MS. Second is the gap between the second heart sound and the opening snap. More the gap, less the severity. And the duration of the murmur. Please remember, it is the duration of the murmur that is important as the severity and not the intensity. It is the duration of the murmur. Okay. So duration of the murmur is basically the marker of severity of MS. Okay. Next we move on to the management and treatment part. How will you manage and treat? So first, how will you diagnose, right? Clinically we have got so many features, but you have to confirm. So what will you get in ECG? You get what is known as the P mitral. What is P mitral? You will get either a bifid P wave or where you will get a notched P wave, right? This is what the P wave looks like in ECG of mitral stenosis patient. Okay. Along with that, in the echocardiography, you can get the distorted mitral valve apparatus. You will get the distorted mitral valve apparatus. It can also help you to know whether you are having any other valve involvement or not. Right, associated regurgitation present or not. If you have read the module on the rheumatic fever, I have told you that we get a type of configuration in echo where this is the anterior mitral valve leaflet and this is the posterior mitral valve leaflet in the echo. So this appearance is known as the hockey stick appearance. This appearance is known as the hockey stick appearance. So you get basically the hockey stick appearance of mitral valve apparatus in mitral stenosis, right? This is known as the hockey stick appearance. Okay. Now, the hot topic area from where you get all the questions. You will get this image based question for mitral stenosis. You get the CXR. Now, what is the first sign that you get? The first sign you get is straightening of the left heart border. You get straightening of the left heart border. Okay. This is due to the enlarged left atrium. This is basically due to the enlarged left atrium. What else you can get? You can get what is known as the double heart sign, double border sign, sorry. You can get what is known as the double border sign. The double border sign is due to the enlarged left atrium, and then this is the enlarged left atrium shadow and this is the right ventricular shadow. Okay. Another you can get is the displacement of the left bronchus. You can have displacement of the left bronchus and you will get predominance of upper lobe veins. You will get predominance of upper lobe veins. This is known as cephalization. Basically, you're going to get cephalization of upper lobe veins. So, how will you manage? How will you manage a case of mitral stenosis, right? So, it can be divided into surgical and it can be divided into medical management. Now, medical management is as important as surgical management. I mean, prior to surgery, you need to do medical management, right? Okay. So, what do you do in the medical management? Number one, you have to decrease the heart rate. So, you can do by giving beta blockers. Okay. These patients usually have AF. If not AF, they have left atrial enlarged or they have history of thromboembolism like stroke, or they have spontaneous echo contrast, something known as spontaneous echo contrast. If not history of thromboembolism, they will have left atrial thrombus. And if the size of LA is more than 55 millimeter, then in all these conditions you have to give anticoagulants. You have to give anticoagulants. Now, if you are asked what is the anticoagulant of choice in rheumatic MS, the answer is only warfarin. The answer is warfarin. All the newer oral anticoagulants like the dabigatran, rivaroxaban, they are not used in rheumatic MS. So, the answer is only one, that is warfarin. That is warfarin. Okay. So, this is a very important question that is asked. So, please do not make mistake that when you are asked whether I am telling you that left atrium is enlarged in a patient of MS and you see a thrombus, what will be your anticoagulant of choice? Your answer would be warfarin, not the novel oral anticoagulants. Okay. What we do with the surgical management? What we do with the surgical management? So either you can do replacement of the valve, right? Or you can do something known as mitral commissurotomy, right? Or you can do something known as mitral commissurotomy, right? Now, when you do mitral commissurotomy, there are certain important things that you need to remember. First, the patient should be symptomatic, having NYHA grade 2 to 4, then only you can do. Then there should be no calcification of mitral valve apparatus, right? There should be no calcification of mitral valve apparatus. If it is there, then you cannot do the mitral commissurotomy. Third, AF should not be there. Okay, AF should not be there. Fourth, the MR if it is there, then it should be mild. The mild grading that they have allowed is up to +2. We have grading up to +2, 3, +4. So they have allowed up to +2. So you can do mitral commissurotomy if the patient is symptomatic. The calcification of MV apparatus is not there. It is not there. Then only you can do. There is no AF and there is very mild MR. Then only you can do the mitral commissurotomy. It is performed by a percutaneous approach. It is performed by a percutaneous approach, right? Now, if all these things are absent, if all these things are not fulfilled, then you will do mitral valve replacement. So, suppose if you have got a severe MR, we'll do mitral valve replacement. If you have got a calcified MS, calcified mitral valve apparatus, you will do mitral valve replacement. If you have got a LA thrombus, you will do mitral valve replacement. If you have got AF, so then you will also do mitral valve replacement, right? And the procedure that there is a technique known as this percutaneous technique, percutaneous balloon mitral valve commissurotomy, right? This is the name of the procedure that we do, and we do by a technique known as INO technique. We do by a technique known as the INO technique, okay? So, this brings us to the end of the module of mitral stenosis. So, let's just summarize what are the important points that we have to remember from mitral stenosis. So, summary. The normal orifice area is 4 to 6 centimeter square. We call it severe if it is less than 1.5 centimeter square, right? We call it severe if it is less than 1.5 centimeter square. Second, we get a hockey stick appearance in echo. We get a hockey stick appearance on echo, okay? In X-ray, the first sign that you get is the straightening of left heart border. Do not forget to see that image-based question that I have given in the module, because that will be asked. If you are asked any image-based question on mitral stenosis, it will be the straightening of the left heart border, okay? Fourth, anticoagulant of choice. Anticoagulant of choice for MS with atrial fibrillation or thrombus, LA thrombus. It is always warfarin. It is always warfarin and not novel oral anticoagulants, right? Then we do MVR, mitral valve replacement, if you have a distorted valve apparatus, okay, if you have AF, if you have a thrombus, and if you have a significant MR. Okay, so these all things are important. Along with that, what is the marker of severity? One last point, what is the marker of severity of MS? One, soft S1, soft S1. Second, the duration of murmur. Duration of murmur is important. And the A2 and OS gap. A2 and OS gap. Less is the gap, more the severity. Okay, less is the gap, more is the severity. So, I have summarized the important points that you need to remember out of this mitral stenosis module. Okay, thank you.